Hello and welcome to today's webinar, Four Dimensions to Modernized Quality of Care, Diverse Perspectives. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available a few days after the session. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen or Command-R if you are using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the handout section at the bottom of your screen. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Eric Schultz, Frank Ingari, Barbara Fox, and Jeff Springer. Eric is the president of FluidEdge Consulting, a Citius tech-owned company. He was the past president and CEO of Harvard Pilgrim Healthcare and Fallon Community Health Plan. He has held executive positions at Cigna Healthcare and served on the board and as chair of America's Health Insurance Plans, the Kenneth Schwartz Center, the Massachusetts Association of Health Plans, the New England Council, among others. At this time, I would like to turn the floor over to Eric.
Thanks, Phil, and good morning to everyone out there who joined us. Thanks for joining us, and I hope on behalf of all of us on the panel that you find this to be informative and give you a few good snippets to take back to your role, whatever it may be on the delivery, payer side, or anything in between. What I'd like to do first is introduce my colleagues on the panel. Let me first start with Frank Ingari. Now we have three panelists here today. Frank is directly representing the care delivery side of things. Frank is presently the president, CEO, and chairman of the board of directors for Tandem Health. Many of you know Tandem Health. It's located in the 5-county region surrounding Philadelphia. In my view, Tandem Health really represents the best of engaging and empowering the primary care physicians, and adding to the primary care physicians a team of other clinicians and support staff, and adding to that technology and a powerful data to produce a great system of care that has made tremendous advances in transforming how care is delivered and improving outcomes for the patient, giving the patient a better experience and the physician, frankly, a better practice experience. And then we have Barbara Fox. Barbara Fox comes to us representing the health plan space, if you will. Barbara Fox is a nurse by training and has had an incredible year career, I should say, in clinical operations, and also combining with that technology solutions to support and improve clinical operations. Barbara is vice president of healthcare consulting at FluidEdge Consulting, and she brings with her a deep degree of experience working with health plans of all types, small and large, and across all product lines of commercial, Medicare, and Medicaid. And last, and certainly not least, we've got with us Jeff Springer. Jeff is the Senior Vice President and Head of Products at Citius Tech. Jeff also brings a 20-plus year set of experience working with some of the nation's leading healthcare technology vendors. And now presently what Jeff is heading up in kind of English terms is the product management and the product strategy area at Citius Tech, and helping to define lots of very cool and effective solutions for his clients in this space. So it's a nice blend of people. We're really glad to have you all here with us on the panel, representing the clinical, the health plan, and the technology side. Let me go to the next screen. The way we're going to approach our webinar today, talking about quality of care programs, is to organize our questions into 4 dimensions. The first is data and analytics strategies. The second is Provider Coordination and Outreach. Third would be management of cost strategies. And last is quality improvement programs. These are really simply guiding our discussions. And clearly, you know, these will blend into each other. They're not as discrete as we make it look here on this slide, but it'll give us some guide. And what we hope to do is to have this conversation and sharing of ideas and experiences, and then also leave enough time at the end so we have 10 or 15 minutes or so for questions. We love to get questions from the audience. You can send them in, or we'll open that up when we get to the end there. So with that, let me go to our first dimension and kind of the first guiding question. I'm going to throw this one out to you, Barbara, to begin with. Can you give us a sense of some of the more innovative approaches health plans can use toward obtaining, you know, data? We know it's a very burdensome, expensive process of gathering data for our clinical quality programs. We know it's important to measure if the programs are making an impact. And frankly, we also know that it has a major impact on revenues coming into health plans, or certainly into systems of care that are under value-based agreements. But can you speak to any ideas that you have that you've seen that have been effective? Barbara.
Sure. This is pretty near and dear to my heart. I spent many years in the health plan space hiring episodic or seasonal nurses to support collecting supplemental data. It's a season of rigorous, manual, costly, inefficient pursuits that all of us have had to endure. In the last few years, I've worked with many of our clients, and we're seeing a trend where those clients are making the necessary transitions away from those manual chart chasing. Aligning business strategies, that's a key, major key, operational and technical solutions. A lot of the operational initiatives that I'm seeing that are becoming more and more innovative is going away from that seasonal chart chasing to collecting data prospectively year-round and improving those member and provider engagement strategies, not just being very linear or single-focused on our approaches. By collecting that data year-round, we've been able to implement very strong clinical actions that can be taken, timely interventions, and quick gap closures. And this is obviously the end result is that overall member care has improved. When the business takes the time to establish a clear predictive model and develop unique to their own health plan membership population, they're able to create priority cohorts, implement innovative strategies, and most of them are starting in the last 2 years to really focus on virtual and digital space for engagement with both the provider and member, really communicating with them at that level to close their gaps and collect their quality data. Technology and automation advances are just booming out there right now in the industry and with many of my clients. Gone are the days of, or quickly gone are the days of where I work with my clients, or all of us in this space work with our clients, and they're solutioning one single problem with one single technology solution. Gone are the days where us business leaders are going to technology and saying, hey, I need to get a better way to collect a single point of data or just my HEDIS measures. Now we want the full circle. And those who have been most successful are taking that approach. They're switching from an episodic to a continuous quality data collection, learning and implementing how to analyze that data. It's so important the business really invest time and effort into that and building out meaningful programs. They're investing funds in technology solutions that really drive that performance management. So the only people that aren't happy in this new scenario are those episodic and seasonal HEDIS nurses and not paraprofessionals who get to earn extra money doing this every year. So that monies and those funds, I'm working with a lot of clients that are shifting those funds towards let's get a solution and let's build a strong strategy. Those are the two key components I've seen.
Yeah, okay, that's good. Well, let's flip this over to you, Frank. Barbara spoke really from the payer perspective. Their changes. Talk about from the clinical side, delivery side.
Well, I think that everything Barbara said makes sense. We like to think about the year as a glide path. So we want to tell folks where they are and where they should be on April 15th, so that we don't create a Q4 crunch as the industry's gotten used to. The other thing is that just from a compliance perspective, it makes more sense all the time to do good prospective health status assessments on your entire panel. You don't want to be cherry picking looking for high risk scores. That's a disastrously bad idea. And we know where CMS is going to go eventually. They're going to be not only allowing you to boost revenue with higher codes, but they're going to be auditing to see, well, did you treat the things that you coded? We haven't had that kind of auditing. We're going to see that kind of auditing come in the future. So I think that we use a metric that's very important to us, which is how many of the codes that are discovered don't hold up to review. And we want to maintain that at an extraordinarily low level. So in other words, you're really always trying to walk the walk, going right down the middle of the fairway, that the prospective health status assessments have to be clinically accurate and clinically driven. And if you stay with that, then the finances take care of themselves. So I would that's all I would add to what Barbara said, and agree with her very much, that you want to make this a constant process, and you want to be applying prospective health status assessments to your entire panel and make it a part of what we do with our patients.
So Frank, curious question. On the physician side of things, this data collection process, so we're talking about it being year-round now, right? What's the practical impact on the practicing physicians and their staff?
Well, it's a burden. There's no doubt, and that's one of the reasons why you've got to compensate properly for this work. In the state of the art right now, doctors in Medicare are being paid more for the documentation than they are for the visit. But that's not a reason not to make it as easy as possible. So what we've been trying to do is really move away from claims-driven suggesting to EMR-based analysis. So we actually have gone to teach the docs to fish. So we teach them how to go through their EMR to find the information that suggests a need for examining a certain clinical parameter, for example. We merge that with claims-based information, but it works a whole lot better when the docs are working through data they've created in the first place. You obviously have a much higher trust level there, and then you augment the payer side.
Got it. That's helpful to hear. Jeff, thoughts on this from a technology perspective?
Yeah, I would think about this from two perspectives. So 100% agree with Barb, the goal of removing the chart sheets, removing the manual from the payer. There's a few things the industry is doing to try to enable this, trying to enable true interoperability. So there was some mandates coming out around FHIR, but FHIR is producing data out. Payers especially have to look to consume data in, and providers and EMRs are going to be mandated to produce data out that can be consumed by the payers as well. So the initiative is largely on the payer side, but it's moving to the provider side. That will help. What we've seen historically is with data that's produced by the EMR, whether it's FHIR now or previously with CCDA HL7, we had one customer close over 100,000 gaps by integrating CCDA into their solution from a clinical data repository perspective. So that can remove a lot of the manual effort. And then moving to what Frank was talking about, management of each patient, this has to be within the concept of what providers are doing. So providers are already overtaxed. I have 15 minutes to see the patient. You want me to do these other 30 things. This is where technology can help as well. So instead of managing the process all retrospectively, hey, I'm going to produce a claim, then I'm going to produce analytics on that, and then I'm going to tell you what you missed. With FHIR and then with workflow and really giving a notice to here's the data needed to close XYZ, whether it's a gap or a risk score or whatever it might be, moving closer and closer to that at the point of care without overburdening the provider. So technology can help in multiple ways. The two broad themes here of removing the manual effort, whether it's chart chase and managing each patient, both will be critical from a data collection, and technology can help, one, with standards like FHIR, but also then with consuming data that's out there like NLP and others as well.
So, Jeff, you brought up the point of FHIR and interoperability. We didn't talk about this much prior in our conversations, but how has the requirements that's being placed on health plans for interoperability, how does it impact data collection? Does it help it? Is it a strategic value, or is it just one more thing that doesn't add value? What's your perspective?
This is a question that's up to the health plan. So there are two ways you can approach this, either as a check the box on the regulatory, I'm going to produce FHIR out as a separate system, or you can take it as a strategic approach to integrate into your whole clinical data repository and interoperability strategy. And if you do the latter, it really can bridge a lot of gaps. And if we fast forward 2, 3, 5 years, we get to the vision that Frank was talking about of how do you have real-time communication around the data I need. Unless we all think about this strategically, you can't have that coordination, because the integration that would be required to achieve that across our whole industry is impossible. So I would strongly encourage payers and also providers to think about this as a strategic initiative. Think about your clinical data repository, data in, data out. There's other things the Interoperability Act did not cover that you'll need to do as well, mastering the data across the feeds coming in is just one example of that, but there are multiple examples. But this is really a foundational item, I think, to truly digitizing healthcare.
So thanks on that, Jeff. And Frank, let me throw this one to you next, and it flows pretty well from what Jeff was just talking about. One thing we do know over the last decade, if not more than that, is the best outcomes in clinical care happen when payers and providers find a way to work together and to collaborate and bring the strengths in their roles to the table and to eliminate duplication. Easier said than done, I know. But on this question here, what are your thoughts on how providers and payers can collaborate better so that it supports this flow of information among the entities, again, to produce a better clinical outcome and experience?
Well, two thoughts. One, I've always said that the most important technology in healthcare is contracting. So the way that we set up the business relationships between the payer and provider is really the most important thing. And there's a lot known now. It's not 2010. It's not a mystery how to set up incentive programs that work for docs. But the second piece I think is very important is that what Jeff was talking about with the interoperability movement is also having a profound impact on the vendors. And I think that's really powerful. So we're starting to see now that all the pop health platforms, Arcadia, Innovacer, and DataLink, and companies like this are all putting pop-ups, context-sensitive pop-ups in the EMR so that the doc sees what the pop health vendor, whether that be an MSO like Tandem or the payer's pop health organization or the hospital's own pop health organization, whoever is taking accountability for suggesting on quality and HEDIS gaps and also on prospective health status assessment gaps, now have a vehicle to put that pop-up context sensitive at the single patient level. That's really powerful, and I think it's putting pressure on some of the vendors who've been reluctant in the past to let anyone into the walled garden. We're starting to see now quite a spectrum of openness on the EMRs, from still pretty rigid, you can see the pop-up but you can't touch anything in the EMR, to a much more integrated approach. And I think the interoperability mandate is going to start to translate into pressure from both payers and providers on the EMR vendors. And I think that's a place that we're going to see a big breakthrough in the next couple of years.
Mm-hmm. Let's hope so. Barbara, from your perspective, what are your thoughts here?
Frank is spot on. Traditionally, the payer environment is all about communicating with the providers through a portal, through a dashboard environment and look. And we all know the reality of it is the actual provider or practitioner is not the one accessing that information. So it's lost in translation, and it never really gets to the point of service with that member or that patient. So I think that's huge, the vendors that are out there doing that integration with those pop-ups. I think the next evolution is that bidirectional communication through that same mechanism. Also, I'm starting to see more and more risk-sharing arrangements coming on board, not only just looking at incentivizing the providers, but let's go into this more as a risk-sharing approach. So I'm seeing more and more of that, Frank.
And, and that's good to hear, Barbara. When you say you're seeing more risk-sharing arrangements emerging, are there any themes, or what themes can you speak to that you're seeing out there?
Well, I'm mostly seeing it in the Caden Care world, where they have their provider network and they're able to leverage that tightly woven integrated network and coming to terms with risk sharing rather than incentivizing. They're sharing the risk, and if gaps aren't closed, then they're both taking a financial burden.
Got it. And when you see these health plans first getting into risk sharing arrangements with providers and practitioner systems or groups, I recall in my experience, we would kind of follow a continuum. Maybe the first step might be with an upside benefit, identifying clinical measures for performance review. Any thoughts on how the new entrants to value-based care are approaching it?
So the few I've worked with on the value-based approach is taking clear metrics and phasing that approach in, rather than a very shotgun approach to it. They're being very clear about what those metrics are, the metrics they want to look at. For example, around the comprehensive diabetes care and around blood pressure measures. They may take two key indicators that they're having challenges with and build their arrangement around that and then move forward once they see success. So they're looking for longitudinal success, not just a one and done.
That's a good segue to the next question. We all know that
Eric, can I just jump in on the last question? I just want to
you absolutely can, and I was going to throw this one to you so you could kill two birds with one stone. But jump in, please.
Yeah. So on the last question on dealing with providers, I want to make 2 points. One is around the outreach and coordination with providers. So Frank touched on having a single place where you can see what's going on with the member or the patient, depending on which side of the equation you're on. But if you think about organizational design, you've got a HEDIS group, you've got a STARS group, you've got a Pop Health group, you've got a value-based group. The coordination of all of those folks then wanting to reach out to the provider, and then Frank took it to the member, is critical. And from a technology perspective, even though you have separate groups, you need to make sure you're speaking as one voice as the organization, so you're not hitting up the provider or even the member 5, 6, 7 times. We've seen payers have 5, 6, 10 different groups that are doing outreach across these things. So from a coordination technology perspective, that's one piece that's integral. The other piece that's integral for this coordination is communication across providers. So take something simple like a transfer, and the notification of your post-acute providers who would then need to see a patient 24 hours later. We put in an alerting system, and we saw a massive uptick in home health SNF visits 24 hours afterwards because they didn't know. And so it's not just how do we coordinate to the member or just value-based. There's all of these programs. They're not going away. One thing we're sure of with healthcare is we'll continue to innovate. The question then becomes, how do you do both organizational design and then community system design to make sure everybody's speaking with one voice? And if you think about this from the provider's perspective, as Barb was talking about, I'm going to have a value-based program, but that provider is dealing with 5, 6, 7 payers, and then they have all of these outreaches from multiple payers. So the coordination here is critical in order to get stickiness with the providers. We're talking about that coordination being critical here. And so think about that, and this is where the technology strategy can help along those lines.
Perfect. So good segue. Let's talk about practice pattern variations. We all know they exist out there. When we're measuring across certain clinical conditions, what experience do you have and what thoughts do you have on this, where we can identify opportunities to improve the outcomes, let's say across a particular disease or health condition? Frank, yeah. and then Jeff, or who wants to go first?
Yeah.
Go ahead, Jeff, start.
Yeah, so there's 2 halves to this, and I'm going to talk about the cost side first. I know Barb and Frank have a ton to say around the quality side. When you're looking at finding these patterns, you have to start with like for like. So what is the population that you're comparing against each other? You can't go, oh, this patient is high cost because, look at the cancer patients, the renal patients, they're always high cost. You really can't do a lot about them. So what you have to do is look at variations in care, and you can use the variations either within the network to see them or benchmarks, national, local, whatever the benchmarks are, and then determine, okay, I've got high variation, why? So is the variation due to a particular provider group? Is it due to some demographic? Is it due to a benefit plan structure? I had a customer who basically were taking a Six Sigma type approach of asking this question on a quarterly basis. They were looking at pure diabetics, not diabetic, asthmatic, depressed, so just pure diabetics. They started off and they found the first problem they had were diabetics weren't taking their statin drugs. They ran a campaign to improve statin drug uptick. It was a mail-in campaign. It wasn't providers involved. That was actually fairly successful. They saw a 67% uptick. They ran that same statistical regression on that population. They found it was a geographic problem in poor neighborhoods, transportation, communication, education. So they ran a transportation education campaign to those. And then the third month they ran it, it was particular to providers, and they went out and talked to those providers. So this is looking at like for like, then determining what are the underlying factors, and then creating a focus around it. There's so many things you could do, and it could be, I'm always going to reach out to providers, I'm always going to reach out to members. I would encourage you to look at what are the true root causes of that, and a statistical type of regression, machine learning algorithms really help here from the cost perspective, because the cost strategies aren't always going to be, I'm going to do less scans or I'm going to change my practice patterns. In fact, often they're more systemic things from a benefit design structure perspective or psychosocial issues, like a few of them that I mentioned.
Thanks, Jeff. Frank, thoughts on this one?
Yeah, I think that sometimes it's really basic things that get in our way here. Now, I'll give you an example. A number of payers don't really do data gathering at the individual doctor level. So a lot of their informatics, having been accreted over the years, built up over the years, will have made decisions at various times that, gee, going to the physician level is too hard because attribution is challenging or whatever. And so we'll get results at the practice level. And that's often misleading because typically what you'll find is that there's a range of problems with a practice that's an outlier, and a significant part of the time it'll be one or two docs out of a group of docs who may be practicing quite differently from the others. So sometimes it's really simple things that account for a lot here. The other point I would make, and I think Jeff alluded to this, is that, well, if you think about over the last 10 years, as pop health has matured, one of the things we've realized is that simple analysis around one variable or another often doesn't give us an actionable answer. You've got to bring different sort of lenses to the same population, including, as the obvious case, which Jeff alluded to, is the SDOH factors. But there's so many different factors that you've got to look at, so that when you speak with docs, you speak with credibility for them. Because one of the things we know from doing this for a lot of years now is that it's the analogy that in customer support is that an unhappy customer will tell 10 people, a happy customer will tell one person. Well, I think that goes in with docs and informatics. Bad data, docs turn into elephants all of a sudden. They never forget. So trying to strive for really, really high fidelity in our analysis is very important here. And I think when it comes to practice pattern variations, you've got to be able to go in and explain what you're seeing in a way that is credible to the docs. You got to be able to back it up. If you can do that, then there's typically going to be a lot of value when you find true variations. And one of the things that struck me in looking at the 5-county network around Philadelphia is that some of the very large hospital systems who have many, many PCPs, they'll have some of the very best practices and they'll have some of the very worst practices. So one of the things we note is that you've got to pay attention to the complex web of practices. So, is a practice location, or is a practice a large group of docs who are affiliated with a hospital? And oh, by the way, if they're affiliated, do they perform the same as the ones that are owned by the hospital? So you got to, again, it's almost like when you're at the optometrist and they're swapping those lenses. You've got to look at the practice through a number of lenses if you're going to have a conversation that's based on credible and recognizable analysis to the docs.
And Frank, just on that before I turn it over to Barbara, so when you're running a practice of physicians and you're working with, let's say, 5 different payers, right, and they're providing you with information, what's the impact in terms of bringing that all together and turning it into something that's valuable for your physicians and their staff so that it is received and viewed as accurate and beneficial and all of that? Where does that all happen?
It doesn't. It's a nightmare. CIO of Beth Israel told us that this was years ago. We were interviewing when I was at Lumeris, and she told us that they had 15 payers, not 5, and that each of the 15 payers had 5 different value-based programs that they were expected to pay attention to. So it was 60 or 70 different programs. Now they revolve around common things. So there's a common HEDIS data set, right? There's common cost foci, but each payer puts it out in a different way, emphasizes different things. So it's not happening right now. And the interoperability movement is not enough. This is going to take a while. We're starting to see some innovation, for example, in the EMR space, little cloud-based vendors like Elation Health, who are designing EMR post value-based care. In other words, it's not designed from the fee-for-service perspective. It's designed thinking that what docs need to do is comply with value-based programs. So they're doing the job of trying to hide the payer program variation from the doc by having the care gaps come to the doc the same way whether they're coming from one payer or another. So I think that may be some hope for the future. But right now, this is pretty much an unmitigated source of frustration for doctors and practices, I would say.
Seems like we're always still looking for that hope in the future for the last X number of years, right? Barbara, maybe. Go ahead.
I was just going to say that it is true. We're on a very slow pace in our industry relative to other industries. But if I look back to 2010, you have to look 10 years, but we have made progress. I like to talk about Pop Health 1.0 was really based on claims data, and it was generating rosters of patients with fairly low fidelity, which we put in a portal and expected the doctor to go and find. And if a patient had 5 care gaps, that would be in 5 different reports because we sorted by care gap. And then the doctor had to go stitch together your informatics. I think about 2021, we have come a long way from that. We're starting to do much, much better. But it's glacial, but it's our glacier,
Yeah, this is true. Barbara, give us some hope. How do you see this, and what do you see happening?
But more at the grassroots level within the payer environment is around those care management programs they build. We're still seeing the trend of let's check the box. Let's check the quality box. To Jeff's point, for the diabetics, we're putting them all in one big cohort. And then we're starting to segregate them into smaller cohorts. But the care management implementation is the same. The same assessment, the same interventions, the same identified problems and goals, and we're not making the initiatives appropriate, or let me change that. We're not growing our approach to care management to that actual member engagement unique to those cohorts. So I'd like to see in the next few years a bigger shift to that. Instead of just building in their platforms the assessments and opportunities, goals, and interventions to be boilerplate, to be more unique to the populations and the smaller cohorts, and really have meaningful engagements with these members.
Yeah.
And better outcomes.
What's that?
Yeah, the one thing that I would add to that in terms of addressing what Barb was talking about with the way people looked at it 10 years ago, so care management has been around forever, and then what Frank was talking about, an improvement in the technology, I'd point out Tandem itself. So what you're seeing in the industry is we used to have just payers, providers. You're having all of these companies come up with different innovative ways to provide care and new companies approaching it in different ways. So whether you've got the Tandems of the world or other models that are out there, we're looking actually to change not just the technology, hey, we're going to introduce a Pop Health solution or an interoperability solution, but people are actually changing practice patterns to do that. And the value-based care arrangements that we have are driving some of that initiative. What we have to do as an industry is change the focus from payment is 90% fee-for-service to payment is less than 50% fee-for-service to drive that type of thought process. If I'm going to get paid 90% based on fee-for-service and I'm a provider, I'm still going to see a patient every 15 minutes. You've got to get out of that paradigm. You've got to think differently. And the pieces that Frank was talking about and Barb was talking about, we bring that together. The change that I've seen is really new models and new companies like Tandem popping up that really can address and shift healthcare in a big way.
So good points, all really good points. I want to remind our audience, if they have questions, do feel free to post them in. Here's the last of the 4 dimensions. And what we were talking about here is for each of our panelists to talk about what they've seen and how they've created processes or strategies for the clinical program people and the IT departments to come together, bring their assets to the table. What strategies, creative strategies you've seen created that has advanced your quality improvement programs. Let me start with you, Frank, on this one.
Yeah, I think that I'll make 2 points. One is that we now know an awful lot about the techniques that work here. You know, how do you get to 4 stars? It's not a mystery anymore. It's a function of will and investment and willingness to collaborate with providers. But the second point I'll make, and I'll come back and talk about what that looks like. The second point I'll make is that this is all about to be blown up by what's happening with star ratings and with direct contracting, and the government's very heavily shifting quality measurement to a more Silicon Valley style of consumer, digitization, and just saying quality is what the patients say it is. And that's going to really drive the kind of innovation Barb was talking about. We have to really look at sort of root cause, not just coming from our traditional viewpoint as payers and providers of dividing people into cohorts, but reacting to the patient as the patient presents themselves and sees themselves and thinks about themselves and their situation. I think that's going to really call on a whole new set of techniques we don't know. But what we do know today is how to do HEDIS. There are well-established techniques. They are very burdensome by their nature. We have a lot of metrics, a lot of measures that have to be tracked. You've got to have the systems that identify the tracking. You've got to then incentivize the tracking. You've got to monitor the tracking. You've got to report on the tracking using where are you at year to date kind of shadow measurement. What we have found is that we have very, very effective quality programs, but they are very detailed and they're very burdensome on the docs. Exactly as we're finally getting really, really good at it, and we pay handsomely for it, here comes star ratings saying it's going to be all patient experience. We have to kind of start over, because that's going to be a very, very different set of skills, I think.
Yeah, that's for sure. That'll be an eye-opener, certainly for the clinical world and the clinicians, for sure. Hey, Barbara, how about from your perspective?
I think that where I see the most impact is really opening the eyes to population care management approaches versus telephonic one-on-one care management approaches. It's challenging a lot of payers to think outside the box, and rather than have siloed approaches. You're right, Frank. We've got HEDIS down, right? Everybody's got their program. They're very focused on it. Their stars, and all of their quality and regulatory. But over on the other side, we have all of the care management initiatives, medical management initiatives within a payer that are very disparate. So bringing it together and having a single approach to this and moving outside of the comfort zone of that one-on-one telephonic and looking at different ways to do it. There's a lot of great stuff out there going on around food as medicine. We need to bring that into the payer world. We need to start helping them see things differently and collaborating closer. The special needs programs force us to collaborate with providers, but we need to do that for all the member population in a very clear, succinct way.
Mm-hmm. Jeff, thoughts from your perspective?
Yeah, so what I would say here is this is around a question of what's the best way to drive coordination and communication around improvement. And so the plans that I've seen improve most in terms of their STAR scores are ones that establish really good relationships with the providers and not just have, the here's your gaps kind of conversations, but a strategic conversation at the beginning of the year. How do we want to coordinate? How do we want to communicate? Can we set up a digital exchange of data? What's the larger plan around that? But if you think about that to the next level, and this gets to Frank's point around member engagement, member satisfaction, patient satisfaction, who is closest to that patient is the patient themselves. And then who is next closest to that patient is the family members. And so when you're talking about good quality of care, it's coordination not just at the let me talk to my providers better and have good coordination of that. And this gets to the point that care management, which is Barb's point, has always tried to do. How do you engage best? And I'll tell you a little bit of a personal story around this. My dad's been diabetic for 50 some odd years. His type 1 diabetes diagnosed when he was 19. And up until about 4 years ago, he was doing finger sticks and manually giving himself his insulin. He had probably 2 to 4 ED visits a year. My mom was going in for surgery, and we were worried that he was going to have an episode, and we said, Dad, you either have to come live with us or get a CGM. He said, there's no way I'm living with you. Well, won't make any color commentary about that statement, but so we got a CGM, and what happened is, since that point 4 years ago, we've acted as a monitor remotely for him as the family members. He has had 0 ED visits since. And so it's thinking about how do you do that coordination. His satisfaction level with his provider's gone way up, even though his provider really had nothing to do with it. And so how do we engage members? How do we engage families? How do we engage coordination? And then how do we engage payers and providers together? So payers have a ton of resources, providers have the relationship, the family member is closest, and then you have the patient themselves. And I think you have to think about journey mapping as a whole entity at all of those levels in order to take healthcare to the next level.
Thanks for sharing that story, making it real, Jeff. And so now to our panelists, we've got a number of questions that have come in, and we'll use the remainder of our time. First question is there a publicly recognized program where health plans and providers have attained patient and member care improvements along with satisfaction in the provider groups with incentives? Who would like to take that first?
Can you repeat it, please?
Sure. Are there any publicly recognized programs where health plans and providers have worked together where they've actually brought about member improvement along with a clinical improvement, along with satisfaction in the provider groups? So it's really, it's both sides, the provider sat and improvement, member sat and improvement.
Can
you think of any programs now?
Yeah, I think that the quintessential program for that right now is the star ratings in Medicare Advantage. That it measures exactly those two things, and especially with the shift to 34% of the value of star being patient experience, and then a huge slug of HEDIS, and then some administrative stuff on things like all-cause readmission. Star is probably the best such public measure that we have because the results are public. I think it's awfully good. It doesn't cover all of healthcare, but I think it does meet that goal. It's interesting because there's no sort of awards. We don't have an Oscar awards for this. Maybe we should, but a 4.5 star rating is a pretty good proxy for what the questioner poses, I think.
Got it. Any other comments on that question? Okay, another question here. Do you see automated IHI trigger tools playing a role in future quality improvement programs and payer incentives? So for the Institute for Healthcare Improvement, any thoughts on that? There you go.
So, I would, no good thoughts, but the one thought that I would have is that healthcare has gone through a series of innovations and is sort of reconnoitering towards how do we improve care and quality and cost altogether, sort of that iron triangle of healthcare. I don't think we're done innovating as an industry. We still have big problems to solve. Frank talked about it, of managing each member, each patient. In order to get to that level, we have to get to more real-time communication coordination. And I wouldn't call it alerting. I would go to the next step of making sure it's in people's processes so that you can manage the patient correctly at the point you're managing them, whoever you are, whether you're a provider, a care manager, nurse navigator, even the folks who are a little bit more removed, contracting, network management, so on and so forth. So I do see the industry continuing to innovate, and that is certainly something that could be on the table as we continue to innovate to find solutions. So pop health was a non-existent concept 10 years ago, to Frank's point, and now it's part of our standard vocabulary, and people are moving more and more to value. That innovation will continue until we really control our costs and quality, which we're still a long way away from.
Another broad question that came up, and you guys touched on it a bit earlier, is member engagement. From a physician perspective, anything we can do to help the physician to get her or his patient more engaged and taking ownership. From a payer perspective, certainly we want to give more control to the members so they have greater ownership and they feel like they're directing their benefits and their care. So general question to the three of you is, can you cite I'm sure you can cite many, but why don't you cite a specific example of an initiative that increased member engagement or patient engagement that you feel has made a real difference in your clinical quality programs that you've seen? And Frank, just to deal with your question, when patients are going to be asked, how do you feel your quality is for you? I mean, this is going to play into that, I think. So let me turn first to Barbara.
Absolutely. I just did a recent initiative moving from the retrieval process for members to go into the portal, which portal adoption is usually quite low, to retrieving either educational information, gaps information or interventions where they need to take some actions on, or just communication with their care manager or the health plan, to meeting the members where they live. We all have one of these, and moving to a digital format where this particular health plan, we started pushing the information to that member, and we saw greater quality from those engagements. Very, very low number. It was a very short pilot. While I was there, there's about a 3-month period, and we were tracking and monitoring the adoption of it, and very few stopped the push notifications. And they were a very thoughtful, well thought out strategy on what we were pushing to that member. And everybody has a phone. Everybody has a phone nowadays. So this particular provider had a relatively large displaced and homeless population, and we were still able to meet them right in their hands. And it was pretty exciting to see that shift.
Thanks, Barbara. Frank.
Yeah.
So I would say that the most effective thing we've seen recently is essentially co-opting the CAHPS survey. So the CAHPS survey has been used as a very blunt instrument, very, very far fringe of statistical significance. So, a plan I know, 100,000 lives in Medicare Advantage, got their CAHPS score based on 200 completed surveys. It's a statistician must be having second thoughts about that. So what we did was launch a 10,000 member survey. So just completely blew up the paradigm, because at 200, you had no information at the practice level. So all you knew was that the payer was doing lousy or doing well, but it didn't tell you anything about your practices. So by going to a very, very large survey, we got the obvious benefit, which is, at least for the larger practices, we had statistically significant survey data for the practice. We could say, well, you guys have a problem with after-hours support, or you guys have a problem with smoking cessation conversations. But the unanticipated benefit was that we got a pickup in consumer engagement in terms of time spent on the phone and other metrics that we track. So I think just some really, we're really behind on consumer digitization in our industry. So some of the very basic things, when you take your car to get serviced, you get a survey right afterwards. As an industry, we're barely doing anything like that yet. So I think there's an awful lot to be learned from the successful adoption of omni-channel techniques in virtually every other industry. I mean, we're really laggards here.
Thanks, Frank. Jeff?
Yeah, I have actually two fun stories here. So the first one was back to that practice pattern issue. One of my customers saw an issue for asthmatics as high flyers from certain zip codes when they actually went out and visited them. So this gets back to the Barb's care management approach. They saw it was from a series of poor neighborhoods and they had very poor air quality. They actually bought them air conditioners because they didn't have air conditioners in summer, and their ED visits went down precipitously. So they were having problems due to their environment at home. A $200 air conditioner saved multiple ED visits for them. So that's one where you can figure out these patterns, and I'm sure those members were much happier not having to have an emergency visit. The other thing is concept of impactability, and so having tools to engage patients and members when they're most impactable is important, and having different strategies at different points in time. So 6 months after you're discharged from a hospital visit, when you're most impactable, and getting them on the pattern that they need to follow is really important, and then follow up and engagement. So how do you engage in an automated way? And this gets to Frank's point on digitization of tracking when they fall off the wagon. So how do you track that they're taking their drugs, they're doing their follow-ups, they're following their exercise plans, whatever it might be. And there are ways you can track and coordinate, communicate. Some of the best initiatives I've seen is where you're doing, having a constant communication with those patients in a very easy way, a quick text, email, phone calls, and it's different for every patient, what they best respond to. And that's easy for them to coordinate around, and playing on that impactability and keeping them high impactable is important. And you can use a lot of technology solutions to make that low touch, to then not have the provider having to do that, but have the coordination and the technology drive a lot of that interaction.
Thanks, Jeff. Let's see, I think we've got time for one last question and no more than 1 minute of an answer, but hopefully I'll get this question right. What are your thoughts on the certification of data aggregators for exchange of data as a mechanism to lighten the load to health plans for non-standard supplemental data reporting? By a show of hands, who would like to try and answer that? We're going to have one person to respond.
Could you just repeat the question? I'm sorry.
Well, all right. So what do you think about data aggregators for exchanging data and using this as a mechanism to lighten the load of this challenge for health plans that have to collect non-standard sub-data? All right, Jeff.
So one of our customers worked with their EMR vendor. One of our payer customers worked with their EMR vendor to collect all of their data from the EMR vendor directly, not from the provider each individually. And so the EMR vendor acted as an aggregator for all of their providers, and were able to send CCDAs for each of those providers. So there is definitely an opportunity for the connection not to be provider by provider, but at an aggregate level. And that customer got over 1 million CCDA records and closed over 100,000 gaps based on that. And so definitely a place for that.
All right. With that, I want to thank everyone who attended the webinar. I hope you found it helpful. I also want to thank America's Health Insurance Plan for helping to put this on, to Citius Tech for being a sponsor of this, but especially I want to thank Barbara Fox from Fluid Edge Consulting, Frank Ingari from Tandem Health, and Jeff Springer from Citius Tech for being our webinar panelists today. Did a great job. Thanks for sharing your insights, and I wish everyone a great rest of the day. Thanks all.
Well, to our speakers, thank you for that great presentation and for sharing your valuable insights. Thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you once again, and enjoy the rest of your day.